Hello, my name is Ben, and I'll be discussing cold intubation within Queensland Ambulance Service, a skill which is reserved for critical care paramedics. A cold intubation is defined as the endotracheal intubation of a patient without the use of analgesia in the pre-hospital setting. This tends to be used in airway protection of the cardiac arrest patient. I will begin by demonstrating the preparation and layout of equipment for intubation in the setting of a cardiac arrest patient. It is important that all equipment is within easy reach of the airway assistant prior to the intubation attempt. In the field, that would be preparation of all the equipment on the right side of the patient, within easy access, and within the vehicle on the right side of the airway seat, just next to the door. It is essential that all equipment is prepared and in easy access positions, as well as being grouped into things that you'll also need. It's important to talk and communicate within the members of your team, especially with your airway assistant. You must understand that their level of experience might not be the same as yours. You need to understand whether you must explain the whole expectation from them, or whether it's just an expectation of the chronological order that you'll be requiring the equipment. And how to perform burp is also essential. We'll discuss that later. During this time, the patient must be receiving optimal pre-oxygenation to prevent further complications. The equipment required includes the Yanker sucker, which is placed under the right shoulder for easy access in cases of regurg. Laryngoscopy blade. This is the Macintosh blade, which is universally used around the world. There is also a Miller blade used for paediatrics. This one here, essential that your LED light is working and that there's no issues with the attachments. The ETT and its appropriate sizings. So we've got 9, 8 and 7 in adults here in Queensland. This is the flexi tip. Today we're going to be using a 7 because of the size of this dummy. However, I've also got prepared a backup of a larger size and a smaller size. I've also got a bunch of airway adjuncts, OPs, NPs and LMAs of all sizes if required. To select a size in QS, CPM has a weight chart which is used in line with the national standards, which give clinicians the following formulas to be explained as per the Children's Hospital in Melbourne's global standard. Number 1, for ETT size, age divided by 4 plus 4. Number 2, for the length at the lips, it is age divided by 2 plus 12. It is also imperative that the clinician has the foresight to have the backups available in at least 3 sizes. You never know, the anatomical abnormalities, the complications you may come across. This ETT cuff should be tested for leaks by the assistant prior to intubation. The outside tip should also be lubricated slightly for help going down the bougie. A Luer-Lock syringe, 10 mils, for the inflation of the cuff, and the bougie, and several other airway adjuncts as discussed before. The cloth tie, which I've prepared underneath the patient, or a Thomas tube holder, which is pretty common around Australia these days, are also available at my discretion. And I've got the bag valve mask with a CO2 adapter. I've also got a working monitor to my left here with ET CO2 monitoring and a sufficient oxygen supply with my suctioning. You are now prepared for a cold intubation. I'll now guide you through a step-by-step process for a successful intubation, and I'll ask my assistant Rachel to give me a hand now as well. I will now guide you through a step-by-step process for a successful intubation. Number 1 is to assess the patient's airway and anatomy for predictors of difficult airway. This can be obesity, short neck, or chest or neck trauma. Have a verbal plan, communicate with the rest of your peers. In the cardiac arrest setting, I might have me and Rachel here on the airway, and I might have Bob on the chest and Henry on the looking at the monitor, yelling out the vital signs to me and telling me about any rhythm changes. All equipment will be tested by Rachel and myself prior to intubation. At this stage, I'm still pre-oxygenating the patient, and I can assume that the crew before I've arrived has maintained 30 to 2 prior to my arrival. While I'm bagging the patient with the CE grip to maintain optimal VVM, I'm going to ask my second officer if she would mind testing the cuff on the ET tube and also lubricating the tip, as well as getting herself facilitated with the rest of the table. At this stage now as well, I'm discussing with my second officer, has she been involved in any of these before? I'm asking Rachel if she's heard of burp.
Yes, I've heard of burp.
Heard of burp? Yep. Wonderful. So what I'm going to do to help Rachel out is I'm going to mark the thyroid cartilage right here, and I'm going to just remind her once again that we're on the same page, that burp is backwards, upwards and rightwards pressure, and if I require it, she'll be ready to assist. All equipment has been tested, and I'm still bagging the patient. I've positioned them with a pillow under the shoulders. This is to assist in the snoring position, creating an access from the mouth to the larynx. Remembering, of course, in a C-spine patient, we will need to maintain Mills neutral position. At this stage, I'll remove the BVM. And I've opened the mouth and inspected for any dentures, plates, to ensure stability. We are now ready to perform laryngoscopy. Got my Mac blade ready, the working light, placing some pressure on my forehead to maintain stability, placing the blade in the right side of the mouth, sweeping the tongue to the left. I'm positioned in the vallecula and I have a grade 0 visualization. Grab my bougie from my partner and that slides beautifully between the cords. Maintaining visualization, asking my assistant to please thread. Once the ET tube reaches my fingertips, I now take control. Looking for the two black markers. Once I'm happy that they're between the cords, having a look, I am 21 at the mouth. I'm going to remove the Mac blade, maintain pressure at the lips, ask my assistant to remove the bougie. Thank you. Thank you. We're going to attach the BVM as well as attaching the CO2 monitoring. Ask my assistant to inflate the cuff. Wonderful. She's going to use the manometer to assess wonderful within the green zone there. At this stage I'm going to assess equal rise and fall, which we're getting. And now my second officer to have an assessment of the airway, of equal air entry.
Equal bilateral air entry.
Thank you. Obviously, that is the first two things we can do, but most importantly, gold standard, our CO2 monitoring. Looking for 6 moderate CO2 waveforms. I'll get my second officer to hold the bag for me while I secure with a cloth tape. I'm going to do a surgeon's knot, which is 2 ties through. Thank you. I'm going to create a reef knot. I'm happy that that's secure, and I'm checking again, 21 at the lips. Now going to ask my second officer for a bite block to complete this process. Wonderful. And now I'm happy. We have now successfully completed an intubation. Furthermore, some complications that can occur. The cuff leak. We have a manometer these days, which puts us in a pretty good position for assessing those. However, the cuff leaks can still occur due to faults in the ET tube. The gold standard is to remove the ET tube and re-intubate. However, sometimes they can be troubleshooted, but it's important to find it and fix it as early as possible. Secondly, gastric regurg, which is a very normal complication in a cardiac arrest patient. We're not going to go through the process today, but that would be the insertion of a gastric tube to remove the secretions. Thank you very much for listening. I hope this has been very informative. I'd like to thank my assistant Rachel, and see you next time.